Uh, we welcome you back on the second edition of our ACE Masterclass, and it gives me great pleasure in welcoming Professor Roger Maggey to us. Professor Roger Maggey is currently the director of the EGP Clinical Academy at Portsmouth University Hospital, England. He resides in North Carolina, USA, where he continues his research and teaching. He was formerly head of WHO Collaborating Center for Diabetes Translation, which was a joint program of IDC and NAMI, as well as a professor of the University of Minnesota Medical School. Ankit, can you mute everybody else, please? Yeah. He is also visiting professor at Nanjing Medical University in China, where he has developed a new research and training center devoted to diabetes modeled after the IDC. He was ex-professor and executive director of the Diabetes Research and Training Center at the Albert Einstein College of Medicine, where he developed the WHO designated Center for Technology in Diabetes. After moving to IDC, he initiated a lot of training programs worldwide. His staged diabetes management is based on a systematic evidence based approach to guide the detection and treatment of diabetes and has been the foundation for many national standards of practice. He's been author to innumerable original articles and several books. More importantly, he's recognized worldwide as the creator of the ambulatory glucose profile analytic program for CGM monitoring. In 2017, in recognition of his achievements, the American Diabetes Association presented Professor with the Harold Rafkin Award for Distinguished International Service in the cause of diabetes. So, a huge welcome, Professor. I've trained with Professor at Minnesota. And when he came to India, I moved around with him in cities. Excellent man at heart, uh, great mentor, and no better person to talk to us this evening. So, I will not keep you waiting, Professor. Over to you to start the proceedings.
Thank you. Thank you very much. Thank you for the generous um, talk about my accomplishments. Um, I'm delighted to be back in India, even if it is virtually, and at least it saves a 17-hour flight. Other than that, I miss India terribly, and I hope that some of your colleagues, and especially you and your family, will one day come to visit us on this side of the water, of the pond. It's beautiful here. It's becoming fall, so we're getting cooler weathers and colorful trees. And I'm delighted to share my work with your colleagues throughout India. So I will put my slides up. Can you see them up there?
Not yet.
Okay.
If you go to
I
share
believe
screen,
I have to share the screen.
yeah, so go to the green button.
I'm looking for the green button.
No, it's
We
right
had this.
down.
Oh, there it is. It's actually a red button on mine.
Okay.
Sign in to share your. Oh, hold on.
No. You have
Ugh.
Ankit, can you guide? Right in the middle of your laptop,
There's no
right,
green button on mine. Hold on. Hold on. Let
Professor, right in the middle of your laptop or your computer, right at the bottom in the middle.
I do not have that on my. Wait a second. Nope. It's got to be somewhere here. Fringe impact more. I see your screen. You have me here. Hmm.
Yesterday, where did you find it in your computer?
It came up when the slide came up,
Right. Do you want to open up your
but it
slide?
says in order to share on mine, I have to sign in. Hold on. Hold on. No, I'm just seeing the Zoom screen now.
Yeah. In the Zoom screen, can you see 8 people?
Oh, now wait. Let me get rid of this. We have too many things up, I think. Let me try it now.
Perfect.
Are we all right? It's the world of technology.
I know. So,
I think it's the 6,000 miles that's causing this.
I'm gonna switch off
I'm
my
ready to go. Shall I start now?
over to you.
Okay. Thank you. Thank you again for the kind introduction. My subject this evening is continuous glucose monitoring and the ambulatory glucose profile as is part of a promise of precision diabetes management. I'm going to use a case-based approach. So at the beginning, I will lay the foundation, and then we will go through a case that we've been following in Great Britain, so we can share how this technology applies to everyday diabetes management. Typically, when we think about diabetes care, we think about the evidence that we need to use as a basis for treating each individual patient. And that is usually beginning with clinical observations, case studies or a little higher level evidence, cohort studies, randomized clinical trials, and then most recently, what we call meta-analysis. Meta-analysis means we take series of clinical trials, we put them all together, and we say, based upon these clinical trials, this is the best treatment we can offer this individual. This is not precision medicine. This is population-based medicine. Precision medicine turns this, as we say, on its head. We collect the evidence from the individual and design the treatment to fit that specific individual based upon the evidence that we receive from the individual. Now, until about 2014, around that time, logbook data and SMBG were the basis of all evidence upon which we made clinical decisions daily as to whether to add or remove therapies, whether to adjust the treatment, initiate a different therapy, and even we used it to find the underlying defect that was causing the diabetes. With the introduction of electronic continuous glucose monitoring, for the first time, we had the ability to determine actually what was happening with the individual's glucose throughout the day in an uninterrupted manner. And over the following 10 years, the improvement in continuous glucose monitoring means that it no longer requires outside calibration. It's calibrated at the factory, and it's highly accurate and reliable glucose data. And so that's where I'm going to begin. As one of the authors of continuous glucose monitoring, I feel it's appropriate that I begin at a level that says the following. We need accurate and reliable data upon which to make clinical decisions. Today, the most accurate and the most reliable data is continuous glucose monitoring. So my challenge with you this evening is to translate the newest technological advances in diabetes, and show you how that translates into clinical practice in order to personalize treatment. Very specifically, I intend to translate the newest CGM technologies into clinical practice to personalize the treatment and to give you a case study to show you how that works. The idea of translational medicine is relatively new. When I started out at Einstein Medical School, the only thing that seemed to be important was to make a discovery which was then published. How that discovery got translated into clinical practice was of no interest to the medical school. And so for many years, publications were the rule of thumb in terms of how you patient to read an article and apply what you find in that article to the treatment of the individual. And many times that failed because individuals are, by their very nature, different. Some are non-compliant. Some react badly to the medication. So in the 1990s and around 2000, the United States government began to give out grants from the National Institutes of Health for the purpose of understanding how you take a new discovery and translate it into clinical practice. I had the privilege of receiving a grant from the NIH, Diabetes Research and Training Center, and the focus of that center up through today is how you take a discovery made at that center or elsewhere and put it into clinical practice. And I hope by what I do this evening, I show you how we think about translating the latest clinical findings and the newest technologies into practice. Where do we begin? Well, first and foremost, we've got to understand what the purpose of continuous glucose monitoring is. In order to make a clinical decision, we've got to measure glucose, transmit that data in a form that's understandable, make sure that the data is accurate and reliable, that is, it can be verified. It can be duplicated if you use two machines at the same time. And we want to use that data to first and foremost detect the underlying defect that's causing the diabetes, and then to use that information, the continuous glucose data, to select, initiate, and adjust the treatment, and to give us feedback as to whether that treatment is working. So let me be clear about this. The purpose of continuous glucose monitoring is for clinical decision making. And as part of clinical decision making, we first and foremost have to be able to characterize the disorder, to identify the underlying defect. And once we understand the defect, to match the treatment to that particular defect. This is especially important in type 2 diabetes, where the individual has multiple defects. And we believe, as I'll show you in a few moments, those defects can be detected through continuous glucose monitoring. So it's my purpose now is to take that continuous glucose monitoring and translate it so that you can use it in clinical practice. In order to do that, several years ago, thinking about diabetes and glucose data, I came up with an interesting concept. I called it ambulatory glucose profile because what it was collecting glucose data from the individual patient and searching for an underlying pattern. When I started doing this, it was episodic data from self-monitored blood glucose. So it was 4, 5, 6 glucoses a day. The advent of continuous glucose monitoring meant that we had 288 glucose values in a single day that we had to understand. We had to put it into some format that enabled us to interpret this data. 288 readings are a lot of reading. It was my hypothesis that underlying these readings are patterns. And once we understand the patterns, we can identify the defect. Once we identify the defect, we can select a treatment that matches that particular defect. So, where do we begin? Well, quantitatively, we know that CGM produces data that gives us the average glucose. It measures variability by coefficient of variation, and more recently, it uses time and range to describe glucoses that are above a target area, within a target area, and below a target area. Is quantitative data sufficient to determine an underlying pattern? I believe it is not. I believe that in order to identify the underlying pattern, we have to be able to see it. And in order to see it, we have to have some form of graphic display. And so, from a qualitative point of view, CGM is represented by ambulatory glucose profile graphic display. Now, what is that? This is the first ambulatory glucose profile ever produced using continuous glucose data. And this was produced back in 2008 when I took one of the first CGM devices, portable devices, downloaded the data it had stored, and then tried to display it in a way that showed an underlying pattern. So what you're looking at here is the underlying pattern of an individual for whom 14 days of glucose data were plotted as if it occurred on a single day, and then 5 curves were used to describe what you're looking at. Those are called smooth curves. The center line, the dark line here, shown here in the center, is the median. The first 2 red lines on either side are the interquartile range. That's 50% of the values fall there, and not 80% of the values fall between the bottom and the top value. What you're seeing here is a nearly flat pattern of an individual without diabetes. And the characteristics that you're seeing is that overnight here, so there's the results of late night snacking, overnight glucose, very tight between these lines, and running around 5 millimoles to 6 millimoles. And then as one gets up and you have morning meal, midday meal, evening meals, you see the rise in glucose, even among individuals without diabetes. But still, in all, it is fairly flat. And so this says to me that an ambulatory glucose profile produced by aggregating the glucose data as if it was on a single day, but it's for 14 days of data, will show underlying patterns. And this clearly shows the underlying pattern of an individual without diabetes. Note there are no values that are very, very high. There are a few values based upon what a person eats that rise to nearly the level of diabetes, glucoses of 10 millimoles approximately, but still does not meet the criteria for diabetes. So this was the first ambulatory glucose profile. Modern profiles are much different. So AGP is essential to represent glucose data in such a way as to do what? First and foremost, to characterize key variables indispensable for clinical decisions. You saw the diurnal glucose profile, but we can break it down even further to look at glucose exposure, glucose variability, glucose stability, risk of hypoglycemia. So let me show you this in a more modern version of the AGP. First, here is the data upon which an AGP is based. This is 14 days of data, of glucose data, stretched out. So it's plotted from midnight to midnight. The yellow areas show hyperglycemia, and a red area would show hypoglycemia, but in this case, there is no hypoglycemia. If we take all of that data and overlap it to make it occur as if it occurs on a single day, we get what I call a spaghetti graph. If I smooth that graph, I get an ambulatory glucose profile. So what do we see here? We see glucose levels overnight from here to here fairly well within the target range. We see daytime glucoses as significantly higher, and that's not surprising. This is an individual, in this case with type 1 diabetes, where insufficient insulin or too much food, too much carbohydrate is causing glucoses to rise and not to fall within the target area. How do we characterize this? That is, how do we measure this using the different variables I mentioned? Well, first, glucose exposure. That's simply the area under the median curve. That tells us, relative to a person without diabetes, how much excess exposure does this individual have? Just by looking at the graph, you can see there is excess exposure during the midday from morning to evening hours. That's reflected in an HbA1c of approximately 8% or 64 millimoles per mole. And we can see that the variability, that the exposure is highest midday here, and again goes up at night, but then starts coming down for overnight. So that is the characteristic exposure. Variability is the measure of the difference between the interquartile range and the interdecile range. So these are two ranges, interquartile here, the dark area, interdecile, the gray area, that tells us how wide the spread is at any moment. One of the things about treating diabetes is that we have to have predictability. The wider the variability, the less predictable the glucose will be, the less predictable it will be, the harder it is to find an appropriate treatment. So what we really want to do is to, in the long run, reduce variability. But in order to reduce variability, we also have to address stability. And stability refers to the movement along the median curve. You can see that the ball is jumping. Let me do that again. Watch the ball jump. That means that the glucose is not stable. If you remember the graph I showed you before of the individual that is normal, the median was a straight line. There was no bouncing around. And then finally, the last measure here is risk of hypoglycemia. So we set hypoglycemia here at 70 milligrams or about 4 millimoles. And we look to see, is there any hypoglycemic risk? And you can see just about over here would be the only time, and very infrequently, is there a risk of hypoglycemia. So in summary, we can look at the glucose exposure, variability, stability, and hypoglycemic risk by one view of this image, the ambulatory glucose profile. I introduced the ambulatory glucose profile back in 2008. I published numerous papers showing how important it was for clinical decision-making, as well as research papers showing such things as the overnight effect of GLP-1s, the effect of long-acting insulin, where the long-acting insulin peaks, etc. And based upon what I did then, and a number of consensus panels, in 2021, the American Diabetes Association adopted the AGP as the standard of care when using CGM devices. It has restated its position every year since then. And in fact, in its publication in Diabetes Care, it shows the AGP report as the standard by which you manage type 1 and type 2 diabetes when using continuous glucose monitoring. Part of the purpose for this was to get the manufacturers of CGM devices to standardize the manner in which they report the data to assist us in our clinical decision making. I have the privilege for the last decade of working with my colleague Ian Cranston out of Portsmouth in England, where he was one of the earliest adopters of both CGM and AGP analysis. And during COVID, the National Health Service of England adopted the AGP approach for diabetes management as its standard for care throughout all of England, training virtually all of its primary care and specialist doctors. I want to take a case that we use for teaching purposes, one that I saw when I was in Southampton, to show you how this is now applied when we're thinking about individual patients with type 2 diabetes. So here we have the case of a 65-year-old male with 20 years duration of type 2 diabetes, obese, and on a regimen that's not atypical: metformin, sitagliptin, and gliclazide. So a combination of 3 different types of treatment modalities in the sense of targeting 3 different defects: metformin for overnight hyperglycemia, sitagliptin for meal-related hyperglycemia, as well as gliclazide or the sulfonylurea. However, as you can see by the profile, that treatment has failed. The HbA1c is 10.5%, the estimated 10.2 based upon the glucose data. And what you can see is persistent hyperglycemia during the daytime and nighttime, wide variability, virtually no hypoglycemia. We set the range here at 6 to 9 millimoles. And so we have a significant problem facing this individual. What should we do for treatment? What does the defect tell us? What are some of the problems in selecting the next treatment modality? Essentially, where do we go from here? If we look at exposure variability, hypoglycemia, and hyperglycemia as key variables, we want to be able to describe them in a systematic way so that a clinical decision can be made and we can measure the outcome once we see what the treatment has been able to accomplish. So I've taken 2 variables, hyperglycemia and variability, regarding this AGP, and measured it on 4 different dimensions: frequency, distribution, magnitude, and duration. So you can see one of the elements of precision medicine is not to summarize all of this rich data as an average glucose, as a means of describing what's happening to this patient. It doesn't tell us very much at all. If we then take each of the variables I've identified and say, describe for me hyperglycemia. Well, it has a continuous frequency. It occurs 24 hours throughout the day. There are no periods, essentially almost no periods of normal glucose level. Some right over here, and we'll talk about that in a moment. The magnitude of the hyperglycemia, that is the measurement from the 9 millimoles up, is 14 millimoles. So 14 millimoles above the normal range. And the duration of hyperglycemia is 24 hours. It is persistent hyperglycemia. So I've given you 4 characteristics of hyperglycemia. It's continuous. It's distributed over 24 hours. Its magnitude averages 14 millimoles per liter. And its duration, that is from the moment it starts to the moment it ends continuously, is 24 hours. Variability, that is the measure of this gray area, the variability or interquartile range. We note the widest variability occurs twice a day, from 0, 200 to 0, 800 hours, and from 14 to 1800 hours. The magnitude of the variability is 15 millimoles. That's significant. That's a very wide variability. And each episode lasts approximately 4 hours. So we have periods when there is very little variability from here to here. And overnight, there's very little variability. Okay. But when the variability does occur, it occurs extensively. So it has an episode of 4 hours. All right. What treatment targets persistent hyperglycemia and variability when sulfonylureas and gliptins result in dysglycemia? Well, we have a variety of treatments, but there is one specific treatment that targets persistent hyperglycemia and variability, and that's GLP-1. It has been shown to reduce both hyperglycemia and variability, and I can attest to that since it is my data and my study, which was the first study to use continuous glucose monitoring with a GLP-1 that showed that it was capable of reducing the hyperglycemia and at the same time the variability. Does it work? So we stopped the sulfonylurea and the DPP-4, and then we started once weekly GLP-1 RA, receptor agonist. So this is the baseline measure here. Remember the variability and the hyperglycemia, and glucose is all up in this area here. After 30 days on a GLP-1, you can see a difference in the profile. I'll superimpose one on top of the other. I want you to note that glucose exposure improved, went from 10.2 to 8.5%. The average glucose went from 13.7 to 11 millimoles. The profile narrowed, stabilized, and lowered. And what I'm going to do here, is superimpose it on top of it. And as you can see, the vast improvement here, especially around mealtime. Here and here, you can see there was a vast improvement. So after 30 days, we have our feedback that suggests that we're going in the right direction. However, this profile is still not of an individual who is protected from long-term complications. We know that long-term complications are associated with HbA1c, and HbA1c is associated with the glucose profile. So in this particular case, we want to now lower the profile so that it stays within normal range. How do we do that? Well, if you look at the baseline, and you'll recall we had 24 hours of continuous hyperglycemia. We had 24-hour duration of hyperglycemia. We look at the GLP-1, and we were able to reduce the magnitude of hyperglycemic events, the duration, and in terms of glucose variability, we were able to reduce the variability to once daily instead of twice per day, and the variable magnitude of 6 millimoles. So we addressed variability in hyperglycemia, but not sufficiently to control glucose levels. So what treatment targets persistent mild hyperglycemia when an incretin glucagon-like peptide receptor agonist results in mild dysglycemia? So I want to repeat that. What treatment would you add to improve this profile? Now, one might say we have a variety of treatments, but which one is most likely to work? So again, if you look at the literature and you look at the data, the suggestion is if the defect is mild hyperglycemia when you've added already a GLP-1, then you need something to give added insulin production or exogenous insulin. And so basal insulin added to a GLP-1 has been shown to reduce hyperglycemia. So start once daily basal insulin at a very low dose, 0.1 unit per kilogram, and titrate to target, not exceeding 1 unit per kilogram. So morning basal insulin or evening basal insulin, it can be either one, would not matter. We're looking for the long-term impact of the insulin at very low dose to allow us to lower the entire curve from top to bottom in terms of improving overall glycemic control. So let's see what we got. Note what happened. After 90 days, continued metformin, GLP-1, with titrated up to 0.6 units per kilogram basal insulin. We have a profile that is almost completely within the target area. We have a stable glucose, reduced variability. The mean glucose is now 7.3, reflected in a 6.2% A1C. So we address the major issues of concern using the addition of basal insulin. This is where we started. This is our baseline. This is where we proceeded to. We got all the way down within a relatively short period of time. We were able to introduce a new therapy, modify that therapy, and improve the overall outcome. We began with a profile that showed significant hyperglycemia, persistent, unrelenting, with high variability, an unstable glucose, and no hypoglycemia. So our issue was never hypoglycemia in the case of this patient. We also were concerned with the BMI, the overall BMI for the individual. When you add therapies that tend to control glucose level, there's often an increase in BMI, especially if you rely solely upon insulin. However, we know that GLP-1s actually help reduce weight. And so in this case, initiating the GLP-1 helped the weight reduction. The increase of insulin did not counter that. And so we did get a net gain, a net reduction in BMI. And if you look at the profiles now, you can see the difference between the two. This one comes much closer to normal and is protective in terms of long-term complications. And we were able to do this by identifying the defect, selecting a new treatment, modifying the treatment based upon feedback from CGM data, and ultimately get full improvement by using that CGM data to titrate the final therapy, which was the addition of basal insulin. So what did the AGP case study show us? We were able to represent the diurnal glucose pattern. Recall that previously we relied on quantitative data, a mean, a standard deviation, coefficient of variation, time and range, none of which showed us the underlying pattern. In this case here, persistent hyperglycemia, persistent significant variability. More importantly, those numbers, even if they come down, time and range comes down slightly, we don't know where it's coming down. Is it coming down postprandial, preprandial? We can see this on an ambulatory glucose profile. We identified the underlying dysglycemia. That individual that we did the case study there was producing insufficient insulin to overcome his diet and his insulin resistance. The combination of the two made it impossible to continue the current therapy that he was on because none of that would help us if he had insufficient insulin, and as it turns out, he did. We were able to characterize the defects with precision. This is precision medicine. This is for this individual. It is not for every individual. The whole notion of precision medicine is personalize it. We could guide the treatment by the patient generating his own verifiable, reliable glucose data. And as a result, we got improved clinical outcome. We reduced overall exposure, that is area under the median curve. Time above range reduced by 95%. Time in range increased by 90%, with no hypoglycemia and with weight reduction. So we were able to reduce the glucose exposure because we could look at it in terms of its frequency, its duration, its magnitude, and how it was distributed throughout the day. That meant we could target a therapy very specific to it, the same for glucose variability. The therapy we needed was one that was 24-hour therapy, not simply postprandial. And we know that a GLP-1 has an effect for 24 hours. If glucose rises above 5 millimoles, it stimulates the pancreas to produce insulin. In this case here, we found, interestingly, that the individual did not have sufficient insulin and needed exogenous insulin, that is basal insulin, to supplement or complement the effects of the GLP-1. In the end, we know we were right because the profile showed us that. Let me go back to that for a second. I want to take you back one slide. The whole notion of continuous glucose monitoring is it has the ability to look at the individual patient, personalizing the treatment. As such, it enables us to take a picture that previously was not possible. Before the advent of continuous glucose monitoring, these two profiles would have been impossible except if done within a hospital setting, using what was known as a biostator, which was a device the size of a table. With CGM, we are not only able to characterize the underlying patterns of dysglycemia, but we're able also to see in a simple way the impact of the therapy. It allows us to make clinical decisions that are supported by the evidence from the individual. We rely on the major clinical trials to give us some direction, to tell us what therapies might work. But until we apply it to the individual, there is no way of knowing whether this individual is going to benefit from that particular therapy. So our case study provided for us an insight into how precision medicine works. In my training, which goes back many years, we sometimes would reduce a patient down to a single number, is HbA1c. We eventually turned the patient into a number. Let's talk about the patient with a mean glucose of this, or an A1C of that, or with hypoglycemia, without giving any descriptors. An 8% A1C can mean any kind of profile that you could possibly think of. In this case, we're back to that same individual with type 1 diabetes, where the hyperglycemia was at the daytime and overnight glucoses were fairly good. We must rid ourselves of reliance on these single measures. Reliance on an estimated A1C, on time in range, on mean glucose is insufficient. The American Diabetes Association happens to agree. And it says, in order to personalize care using continuous glucose monitoring data, which we know to be accurate and reliable, we have to look at the whole patient. It means we have to see the underlying patterns. We have to be able to understand that a patient is not merely a number, and that therapies that work with one patient may not work with another, and there is only one way to find that out: to continuously collect data that provides us with the feedback that helps us understand how effective the treatment is. In this case of type 1 diabetes, the treatment is not effective. We know that this individual needs more insulin or has to change his daytime behaviors so that the insulin that he takes enables him to control his blood sugar. What this helps us do is to target the therapy. He does not need overnight insulin. He needs a bolus of insulin before each meals. And if we treat him properly, we should be able to see this profile come down. One thing I learned of 10 years of following patients and using CGM with AGP analysis, the first step in treatment is to reduce variability. The second step is to stabilize the glucose. Only after you've reduced variability and stabilized the glucose can you lower glucose safely to avoid hypoglycemia. So it's a three-step phase. First, address the variability. Second, the stability. And then third, the dysglycemia or the hyperglycemia. Thank you very much. It's been a great pleasure to once again visit virtually India. This is the center in Southampton. We do not have a physical center in Chapel Hill, except we are right next door to the University of North Carolina and only 15 minutes from Duke University. So we're within a very nice environment of medicine where I still get a chance to meet and discuss these things with colleagues. So thank you very much, and I can take questions now.
Thank you so much, Professor, for the wonderful presentation and a deep insight into how things has been evolved since AGP has come in and how it's helping us manage patients in a better way. And I think we are fortunate that we also have all these things available in India as well, because until recently we just had Libre Professional version. Now we have the Libre normal version, and we are getting all the data, and it's changing the way we manage diabetes. So thanks to all the innovations what you have found us and helping us manage in a better way. I'm just be happy if anyone has any questions, please join in.
So, Professor, excellent presentation as always. Wanted to ask a question. Libre versus Libre Pro means, in terms of you need 4 days to form an AGP minimum.
Yes.
People have started using Libre as a no pre-glucometer. And if they're going to
Mhm.
change their action, how much would that have an impact on the AGP?
Um, the the difficulty, I always looked at ambulatory glucose profile as a tool initially for healthcare professionals, as an educational tool as feedback to an individual with diabetes. We always used it to show patients how they're doing. But in England, when they first introduced continuous glucose monitoring, they made AGPs available to patients. And patients started trading their AGP profiles with one another, their pictures, and talking about what they did to change the profile. They became better at interpreting AGPs than their clinicians because clinicians tended to fall back on a mean glucose or on an estimated A1C, or more recently on GMI, the Glucose Management Index, which now has been disproven. It's been shown not to be reflective of either mean glucose or A1C. So it's something that you will probably stop using, and you're going to probably see manufacturers stopping its use. My advice, and this goes to personalized medicine, I would lay out for a patient an AGP to give them a broad picture of how they're doing. And depending upon your culture and how much data you allow your patients to have, if it goes as far as the US, where we're an open book, where we share everything with the patient, then certainly I would share an AGP with the patient once they understand what its interpretation is. It's imperative that physicians understand it, however. Looking at CGM data without an AGP really is diminishing the value of CGM, I would say, by a good 50%, if not more. I did a paper on time and range where I showed how misleading time and range can be. So a patient, think about this, with 100% time and range in the normal range can have an average glucose of 5 millimoles or 10 millimoles. Well, there's a big difference between the two. The glucoses can all be high during the day and low overnight, low during the day and high overnight. And you don't know that by time and range, only by looking at a picture, an AGP. So think of the patient. When you say to the patient, tell me what happened here. When you look at the individual days, let me just get to that one because it's a very effective way. I apologize for having to go all the way backwards, but I think it's worth it. There. If you say to this patient, what happened in the middle of the day? Look at your glucose. And on this day in February, what did you do that raised your glucose here? You will understand the patterns of behavior that are contributing to the hyperglycemia much faster than any other method I know. And then if you look at several days in a row, sometimes you'll see a pattern where you had 1, 2, 3, 4 fairly good days. Well, I exercised on those days. Well, what happened on this day? I slept in. So now you know the effect of exercise. The richness of looking at these profiles is so much greater than looking at quantitative data that it's always surprised me that physicians don't jump at this. I will also tell you one other thing I told primary care physicians in Minnesota when I lived there, because they manage most of diabetes. I said, I'm making you an endocrinologist, because an endocrinologist takes all the data and looks for a pattern. I'm putting the pattern in front of them. In 30 seconds, they become an endocrinologist. And most of them understood quite well the power of showing this to a patient and what did you do on this day that was so different than on this day? And this is a very good day. So why don't we try to repeat this day and let's avoid whatever you did on this day? So it's a very rich way of treating patients. And luckily now in the United States, it's reimbursable. So a doctor who spends time on this will get paid. And that's the other part that I can't figure out. I would want to spend more time on this than numbers because it shows the patient something. I hope that answered your question. I really don't know patterns of sales in, of Abbott's strategies when it comes to products in different countries. I know sitting where I am, I think in India, you deserve the best of the technologies. There's no reason that you shouldn't have the most advanced CGMs that are available and have access to the software programs that enable use of them. One day, by the way, there'll be a general program that will take all of the CGM data and it'll produce it whatever manner you find appropriate for you in your clinic, because you can have it customized to your clinic. And that may be one of the approaches to take in the future as to how you display the data.
Thank you, Professor. I think that was. How do you see the role of AI in the future?
Of AI in here?
Yeah.
You better watch out. This is given very much to AI thinking. All right. But remember, AI still depends upon the input. Now, this is much better input than a mean glucose. I think you'd all agree with that. And it's much better input than, and so you have a very good point there. A good AI would take a look at this and say, I've got to find a pattern. And I got to tell the doctor about the pattern. Better yet, I'm going to tell the patient what the pattern is. And they can skip, going through the process of analysis. I'll interpret it for them. So all of those dimensions I gave you are AI compatible. So AI can tell you the duration, the time, the variability. It can also tell you in fine detail how much improvement was there. Where was that improvement? What preceded the improvement? What did the patient do? So if you think about insulin infusion pumps, how much AI can help that by looking for underlying patterns and saying, well, to produce this pattern, this is the sequence of events that we have to duplicate. So yes, it has a major role in the future with something like this. As all technologies, as you advance in technology, AI is going to play a more and more important role.
Can I ask one of the things which has been bugging me for a long time, Professor? Is like, why did they choose 14 days as the magic number to allow it to be?
Okay. All right. I'm the cause of that. The 14 days. I was challenged when CGM was first introduced because of the cost of CGM. How many days does a patient really have to monitor, especially with type 2 diabetes, before we can see a pattern upon which we can make a clinical decision? Now, in my training, they used to say 3 days. Look at 3 days, and we knew that that was ridiculous because weekends and weekdays differ and so forth. So we ran a series of studies in which we looked at 90 days of continuous data, and we said, what predicts the 90 days? And we said, well, 60 days predicts 90 days, very, very good. 30 days, almost the same as 60. So then we started cutting back. At 14 days, we still had about 95% predictability of the next 90 days. As you lowered from 14, you lost that ability to make the prediction. Now, an independent group saying, what does Mazzy know about what he's doing anyway? And he's from Minnesota. We're going to test this. And they did it independently and came out with 14.1 days. I think that was pretty good. Since then, it's held. It's held for the last 10 years. And that's why initially Abbott first adopted the 14-day, the censor for 14 days was based upon that principle. That if you had 14 days of continuous data with about 95% certainty, you can say if nothing changes, I can tell you what's going to happen for the next 90 days. And I think it's fairly reasonable to assume that because we don't change our habits that much, that if we take the therapy each day the same way, if we eat generally the same way, if we do exercise generally the same way, there is a predictable pattern. And CGM was able to find that out and prove it. It showed that it was true. Thanks for that question.
Thank you.
As the creator, it's easy for me to answer those questions.
It's fantastic as well, because we get lots of these questions from other practitioners as well. And
Yes,
now we
yes.
can tell it in a better way as well.
Yeah, well, people ask me all the time, how come I present without notes? And I said, because it's my work. So I remember how I did each thing. I remember also the first AGP I ever produced was actually for episodic data, for SMBG data. And it was to show my residents at Einstein that a single value has no meaning in diabetes. So they used to treat by a single, the patient was hyperglycemic this morning. And then they change everything based upon it. So I tried to put it together on a sheet and I'd say, what happened to yesterday morning and tomorrow morning? And 3 weeks ago on that morning. And then they'd say, oh, wait a second, the pattern is very variable. So I said, then you can't predict. You can't treat them on the basis of always having hyperglycemia in the morning. This patient that you're looking at here is fairly easy to figure out. They're hyperglycemic during the day. We have to figure out a change, and it looks to me like it's probably dietary. So you try that first, and then you improve because it's type 1, you add more insulin. So if they're not going to change their diet, you just add more insulin. But in this case here, it would be rapid acting insulin around the meals. And why is that? Because if you did a basal insulin, you'd lower here and here and cause overnight hypoglycemia. So you don't want to do that. So you want to be very targeted on this. It's very rich information. And on the individual days, that helps you understand the patient's behavior more than anything else.
Thank you, Prof.
Sure. Thank you much, Professor. I think you've explained that so lucidly, I'm sure. A lot of the questions that we face are gone. I think we are crossed our time anyways.
Yes.
If there are no further questions, I'd like to thank the professor for his time and his generosity in teaching us and going from the basics to advance for AGP. Praveen, you want to say something to Prof? Praveen is one of our, you're on mute.
I just want to thank him. That's a very, very nice presentation. You made it look much easier. I do interpret these easier from time to time, but my approach is entirely different, the recognizing the pattern, everything. But looking at the AGP, unfortunately, we don't get that much time. That's the first thing, because it's easier to explain to your patient when I look at the individual days and tell them saying that there is a day-to-day variation. So you cannot simply go by 1 day glucose and keep changing your insulin suddenly for the next 1 week.
Right.
That's what we used to. That's what we use it for. And the next thing is when we choose the agent. Like for example, you said in your case you chose for postprandial control a GLP-1 agonist. Do you know how hard it is to convince a person in India to use that kind of treatment? I would have gone for a mixed insulin there straight away, BD,
Yes.
like a Novamix kind of thing.
Yes, I understand, and you're absolutely correct. There are cultural differences. One of the most fascinating things that I found, I was a very big insulin user for type 2s. But right away, let's go to insulin. No, I don't want it. I don't want a needle. I don't want to inject myself. I'm not going to inject myself. And the doctor that I was teaching, the doctors I was teaching were the same as the patients. I don't want to use, they don't want a needle. I'm not going to give them a needle and so forth. Suddenly GLP-1s come. And the words weight reduction suddenly wipe out all needle fear whatsoever. And that taught me one thing. Don't believe the first thing you hear about any of this stuff. Try it yourself, because you're going to find amazing things as technology develops. There's also a sense in some individuals become a little more adventurous. And if you can show them, in our case, both in England and the US, when we showed them their improvements by a picture, not a number, by a picture, where they could see there was significant improvement, that reinforced their behavior. For how long, no one knows. And, eventually CGM, the technologies will be such that the sensor will be almost, you won't even feel, you won't even know you have a sensor on. Once it gets in common practice, it will be used much better and people will find better ways of doing it. In the US, they just now finally have accepted the notion of continuous monitoring as a preventive step. So you have an obese patient who did not develop type 2 diabetes and you want to prevent them from getting type 2 diabetes, you put them on CGM for 2 weeks. You do a thorough analysis of the profile of the AGP and you say, if you're willing to change this behavior, and this behavior, we're going to prevent diabetes from occurring. And I'm going to give you feedback each week so that you'll know it's happening. That was the other part. I thought that CGM would be a boon to American doctors because most endocrinologists had no procedure with diabetes, no material to work with, and a number. And as they became more and more reliant on HbA1c, there was only one number. So you went to see your doctor, he said, oh, you're at 7%, you're fine, go home. But wait a second, I drive home and I get into an accident because I'm hypoglycemic half the time. Oh, I forgot to look at your logbook. Then they look at the logbook and they say, I can't make heads or tails out of any of this. I'm not sure, is it real? Is it fake? Is it's scribbled? Was it done while waiting for me in the office? All of those things. Put that aside and think of modern medicine. An AGP is produced, the data is in front of you. It's faster medicine because it's going to be more accurate than any other means. So in a way, even though it's more technology and looks like it's greater stuff, the decision making will be more accurate, much better for the patient. And after a while, this becomes a teaching tool, something for the patient to learn from, which only reinforces it further. So I can understand differences from, and this is all over the world, these differences. The common thing is, and we've seen this with other technologies, from televisions to telephones to automobiles, and you have to think of this in that same light. This is a technology that's here to stay. It's the future of diabetes management, and what's good about it is it makes it more precise and more personalized rather than less so. And that's the direction we have to take. I've reviewed paper after paper where they're trying to diminish all of this down to a single number, which doesn't help you. Looking at this profile and looking at 8% doesn't help you say anything about the patient's pattern. It's vital that you stick to it, and it will pay off in the long run, I'm sure.
Thank you, Professor.
Sure.
Thank you, Praveen, for your input. And I think on behalf of ACE, if Mani agrees, I would request Mani to give the vote of thanks and thank the professor and close the session.
I would like to thank Professor Rojo Mas for wonderful presentation and giving a huge insight into how things have developed, and it's helping us as well to manage diabetes in a better way. And thanks so much, as Mithun rightly put in, for teaching us and educating us and enlightening us about the whole process. Thank you so much for giving your precious time on a Saturday afternoon, I think, or a Saturday morning. I don't know what time it is there. To
It's
spend
now
more-
afternoon.
It's afternoon.
On into
Okay.
afternoon.
So in a beautiful day there and spending
Yes,
time,
yes.
dedicating the time to us for educating us. Thank you so much. And we hope we meet you in person at some point in India. It'll be very great for us to host you at some point in India as well. Thank you so much for.
Well, thank you. Thank you very much. And when AI figures out a way of transporting me instantaneously from my desk here to a desk there, I will be ready to come anytime, day or night. It's a pleasure, and the benefit of this kind of interaction, it has gotten better over the years, and it has become a little more personal. So I enjoy doing it this way, and I'm always free to do it. So thank you for inviting me. I've had wonderful times in India. I miss India tremendously, and I miss the people particularly. But we're getting so many people from India moving here. I feel all of you may one day be living in Chapel Hill. Who knows? Who knows what the future is? So thank you very much for the kind invitation, and it was a pleasure teaching you this morning.
Thank you.
Good night, Professor.
Thank you.
Thank you.
Bye.
Ankit, do you want to close it? Okay, thank you.
Recording stopped.